First of all, I would like to thank the MedGenome team for allowing us to evaluate their whole genome sequencing for a few of our difficult cases so that we gain confidence, because it's a very expensive assay, a high-end assay, which we cannot use for every patient. And I'll be sharing my experiences with few samples which we are able to do it and what the outcome was. So it's a very limited amount of experience, but still we would like to share, and we would like to create a background how to go about using this particular assay. So this is a usual algorithm for lab diagnosis of tuberculosis. Clinician suspects TB, he sends a sample, we do a smear, culture, and GeneXpert. GeneXpert is the backbone now, and most of us use it very well. And if at all the culture grows, we go for a drug susceptibility testing for the first line. If somebody wants it earlier, they opt for a line probe assay. This is the usual sequence of testing. If all these are available, this is the ideal way people proceed nowadays. Now, a few words about the GeneXpert, which is the backbone. Most of us use GeneXpert very well, and we are very happy with what we have achieved with GeneXpert with diagnostic tuberculosis. An Ultra cartridge has come, which is an upgraded version, which has got higher sensitivity. It picks up as low as 16 colony forming units. And the basic difference is with the previous cartridges that it uses a different target for identification. It uses the insertion sequence for identification. So the sensitivity is far greater. And the resistance is detected by a melting curve analysis for 4 probes of RPOP gene. So it's a very robust and very good method for diagnosing tuberculosis, identifying the Mycobacterium tuberculosis complex, as well as telling us of the rifampicin resistant gene. The limitations of Ultra are that only rifampicin resistance is detected. That madam has already told you. And rifampicin resistant isolates are not MDR by default. But when it comes to rifampicin resistant, we by default assume that everybody is MDR. We go for switch over the second line. So monoresistance for INH and pyrazimide, if present, will never be identified by GeneXpert. And since it is very sensitive, it picks up very small, low quantities of DNA, and they can give a trace call nowadays. Trace means very little amount of DNA. It picked up Mycobacterium tuberculosis, but the DNA is not good enough to interpret the rifampicin resistance, so it gives an indeterminate result. And that's query whether rifampicin will work or will not work. Mixed infections cannot be identified. In fact, if you have an NTM with MTB mix, it can give a false call for rifampicin resistance. And this is a recent study from India in clinical infectious diseases. South Indian strains were typed using whole genome sequencing. They found that 27% rifampicin resistant Indian strains lacked mutations in the normal RPOB region that is targeted in all the kits, that is GeneXpert, LPA, everything. So these 27% resistant genes will never be picked up by LPA or a GeneXpert assay. So these mutations are not there. So that is a concern. Then you have a line probe assay. Everybody knows about line probe assay. It's been there in the market. It's a very good method to shorten the susceptibility, identifying the susceptibility profile of the bug. It's a PCR hybridization technique. I won't go much into it. You have a strip which has got probes, wild type probes and mutant probes. You have a first line LPA and a second line LPA. The absence of wild type probe and the presence of a mutant probe is considered to be resistance. It can happen either way, in isolation, or it can happen together. So first line picks up only isoniazid and rifampicin. The second line picks up fluoroquinolones and the second line injectables like kanamycin, amikacin, and capreomycin. But few genes, only 2 genes are targeted in case of the second line injectables, RRS and EIS. So very few mutations, most common mutations will be picked up. No novel mutations will be picked up by these 2 assays. So what is the drawback? There are some limitations. Cannot replace direct drug susceptibility because it does not include all the drugs. Like first line will pick up only INH and rifampicin, and resistance to second line, all second lines are not identified, and detects only common mutations, no novel mutations. So phenotypically, it may be resistant. Genotypically, it may not pick up the mutation because it is not included in the panel. And the mutation probes will be detected only if the resistant bacteria is at least 5% of the population. So resistant bacteria, if the mixed population, the resistant bacteria should be at least 5%, only then it will be picked up. An absence of wild type probes would probably be missed if the resistant population is less than 95% of the total bacterial population. So these are the limitations of line probe assay. So let me share the few cases that we have done here with whole genome sequencing. Try to solve a few cases. This is a 19-year-old female, pulmonary tuberculosis, diagnosed in January 2020. It's one whole year throughout the COVID, she has been suffering from TB and we have not been able to cure her. January 2020, she was diagnosed tuberculosis, first line ATT started. April again, she came back, smear positive, GeneXpert was done, rifampicin resistance was negative. July again, she comes back, smear is positive, rifampicin resistance is negative, MTB is grown. At this point of time in September, we were really concerned what is happening. We were not able to get the first line DST as of now. So we sent for whole genome sequencing. We sent the sputum as well as the isolate, Mycobacterium tuberculosis isolate that we had grown. In October, we sent for whole genome sequencing. November, again, she comes back, smear is positive, MTB is grown, GeneXpert is done. It's again, resistance is negative. So during July, the district tuberculosis officer added streptomycin and levofloxacin to a regime, considering her to be an MDR TB case. But rifampicin resistance was always negative when you did a GeneXpert. Now, we were worried if 5% resistance is negative, what is happening to the patient? She says that she is very compliant in taking the medicine. So we thought it would be malabsorption. We sent a gastro reference. The gastroenterologist did endoscopy and found ulcers in the cecal. And they biopsied the cecal ulcers. They found it grew Mycobacterium tuberculosis. GeneXpert was trace positive. Rifampicin resistance was indeterminate. So throughout this whole year, she had pulmonary tuberculosis, also developed intestinal tuberculosis. The isolate seemed to be sensitive to first line DST that we ultimately did and came up with the results in November, but still she is not responding to the treatment. This is the whole genome sequencing. Dr. Lakshmi has already told you, this is how she depicts in a picturized form. The green means it is sensitive. The gray means they are not commenting on it as of now. They are newer drugs. The first line and second line all were in the green zone. That is no mutation at all. Now, this is the isolate that they had full sequenced, and they came up with the report, and they said that no resistance is seen. It is fully susceptible, pan-susceptible. However, the sputum, when they analyzed the sputum, they were not able to amplify the DNA, and they were not able to sequence it, and it failed. So the outcome was it's a pulmonary tuberculosis. Ultimately, she developed intestinal tuberculosis also by the end of the year. Sample was MTB isolate. Sputum was sent. Sputum failed. Whole genome sequencing was done. They reported as lineage 1. It was susceptible. And we advised the patient to discontinue the second line drugs, streptomycin and levofloxacin. She can continue on ATT first line, but we were concerned why she was not responding. So we advised her to go for a TDM, therapeutic drug monitoring. She is referred to the Tambaram Center in Chennai, where TDM is supposed to be done, and to find out the reason why she is not achieving good concentrations of drug and she is not responding to the drugs which are sensitive. So we were not able to completely find a reason for her non-response to the treatment, but we found that it is not an MDR TB, it's a susceptible TB. Second case, again, a 70-year-old female with extrapulmonary tuberculosis. Now it's axillary lymph nodes, bilateral axillary as well as mediastinal lymphadenitis with an abscess. February, the lymph node was excised. Histopathology showed classical granulation lymphadenitis, caseation granulomatous lymphadenitis, suggestive of tuberculosis. First line TTT was started. The GeneXpert, however, was negative of the lymph node, but GeneXpert of the pus aspirated from the lymph node was positive. Rifampicin resistance was negative. Cultures were negative. That was we never had an isolate from this particular patient. She was started on first line. She completed the first line in August, stopped the ATT once it was finished, that duration was finished. And 2 weeks after stopping the ATT, she comes here with a massive pleural effusion. We admitted her. We do an ICD drainage. The pleural fluid is GeneXpert positive. Rifampicin resistance is negative. Smear is positive. Culture again is negative. So we don't have an isolate of this patient, and we don't know what happened, why the patient has relapsed and come back again with the infection. So we sent the pus for whole genome sequencing. Now this was the whole genome sequencing result of this particular patient's pus isolate, that's pleural fluid isolate, pleural fluid, not isolate, pleural fluid sample. Isoniazid was resistant, the red zone. Ofloxacin and moxifloxacin both were resistant. Isoniazid was resistant by CAT gene mutation. Now, CAT gene mutation confers high level resistance to isoniazid, so you can't hike up the dose of isoniazid to bring about cure. And the ufloxacin and moxifloxacin were resistant due to mutations in the gyrase A gene. So they gave classically a good report saying that these two are resistant, the reason why they were resistant. And what was the intervention? Extrapulmonary tuberculosis, cultures were negative. So you don't have a culture to do a DST. Pus sample was present. We did the whole genome sequencing. We found that isoniazid, ufloxacin, and moxifloxacin were resistant. The isolate was lineage 1. And the intervention was INH was replaced with streptomycin. Now, if you do an LPA in this patient, line probation in this patient, it will identify only INH resistance. It won't identify ufloxacin and resistance to fluoroquinolones. If you do an LPA, you will understand that it is INH resistant and you will start fluoroquinolones as a second line of treatment. Now, if you had done a whole genome sequencing, you would have known that fluoroquinolones are also resistant. It is not an ideal treatment. Only after 1 or 2 months, when she doesn't respond, you will change the treatment to streptomycin. So in this case, since we had done a whole genome sequencing, we knew that among the second line also fluoroquinolones were resistant. It's better to start streptomycin. Now this is the last case, the third case, which is the most trickiest one. This is a 4-year-old male, a child with critical congenital heart disease, a very bad form of congenital heart disease for which he has to regularly come to a pediatric cardiology department, had undergone certain interventions also. And during this course, he reports one day with seizures to a ER. An MRI shows a big abscess in the frontal lobe. In August 2020, the neurosurgeon comes into action. He drains the pus. The pus showed few bacilli, few acid pus bacilli that we were able to appreciate. GeneXpert of the pus was negative, and we did it twice. Twice the GeneXpert of the pus was negative. Culture pus grew streptococcus. In fact, streptococcus was seen in the gram stain also. The appropriate treatment was started. Culture AFB was negative, so there was no isolate. In spite of keeping it for 10 weeks, we never isolated the mycobacteria from this specimen. So pus was available. We wanted to know what the bacteria is. Now, when you have a condition and a situation where you have acid fast bacilli in the smear and GeneXpert comes negative, it's invariably going to be a non-tuberculous mycobacteria. That's what we assume. And there was no reason to believe that this particular child should be having a non-tuberculous mycobacteria because he doesn't have the predisposing factors for it. So we sent the pus for whole genome sequencing to confirm whether it's a non-tuberculous mycobacteria at all, because we never grew a bacteria to identify whether it's NTM or FTB. The whole genome sequencing confirmed it to be Mycobacterium tuberculosis complex, which was pan-susceptible, no resistance at all. So this was quite surprising, but we were able to rule out non-tuberculous mycobacteria. We have never seen a case where GeneXpert was negative in smear positive cases, but this is the first case that we have seen. So we were surprised. So what was the intervention? So this is a diagnosis, is a brain abscess, extrapulmonary tuberculosis, AFB cultures were negative. So we don't have an isolate to identify. Pus sample was a specimen provided for whole genome sequencing. MTB was identified, susceptible, lineage 1. First line ATT was started. We have to wait and see how far the first line ATT will make a difference. We are observing the child, but this was an eye opener for us that GeneXpert can come negative smear positive cases. Now, a few words on the literature. Now, there is literature on whole genome sequencing in Indian isolates. The South Indian study where Soumya Swaminathan is also one of the co-authors from Chennai, from Tamil Nadu. This study was done. When they did the whole genome sequencing of 200 odd isolates, they found that there were cluster outbreaks in treatment centers. They found out that just because the people were crowding at the treatment centers, they were having the same strains of mycobacteria. So they found out there was an outbreak. So infection control protocols had to be improved in treatment centers. And they found out novel mutations for isoniazide. And they found that 27% of the resistant, rifampicin resistant isolates lacked mutations in the RPOB gene. That is usually not, these mutations are not seen in the commercial assays like GeneXpert and the line-probe assay. It will not pick up by doing a GeneXpert or line-probe assay. This is the second study on whole genome sequencing, another big study where they isolated 300 odd isolates from North India. And they found that 20% of them were co-infected with non-tuberculous mycobacteria. Now, you will never find out this particular thing when you do a GeneXpert or a line probe assay when there is a mix of Mycobacterium tuberculosis and non-tuberculous mycobacteria. They too identified 343 novel mutations which conferred drug resistance and are not currently part of the diagnostic kit. So it will never be picked up by the routine diagnostic molecular kits that are commercially available. So whole genome sequencing will only identify these novel mutations which confer resistance. The take-home message is that whole genome sequencing can be very helpful when you don't have a culture isolate, when you don't have a culture isolate for identification or DST. Whole genome sequencing can confirm infection by Mycobacterium tuberculosis complex. Even when the GeneXpert fails, it can still confirm it. Whole genome sequencing can help identify true MDRs. Monoresistance can be identified, MDRs can be identified, even pre-XDR can be identified. Pre-XDR means any one of the fluoroquinolones or the injectable second lines are resistant, not both. If both are resistant, it's XDR. If any one of them are resistant, it's pre-XDR. And whole genome sequencing can identify monoresistant. So you don't need to discontinue all the first line antibiotics. You can discontinue only the ones which are resistant. So the modified algorithm would be you still suspect TB, you order smear AFP, culture AFP, and GeneXpert. If you are in a tertiary care center where you see patients who are complicated, who come back after treatment not responding, you can directly order a whole genome sequencing in the sample, or else you can wait for the bacterial culture to be isolated. You can send the culture for whole genome sequencing. The advantage of whole genome sequencing when compared to LPA is that you will identify the first line and second line the same setting. You know which second line to be tested. The reason I'm saying is that there is high degree of fluoroquinolone resistance in Indian isolates that we don't realize unless and until we test it. By default, we start fluoroquinolones because it's easy to give and the patient can also take it very well. So fluoroquinolones may be resistant and you may realize only after 1 or 2 months of treating with fluoroquinolones. Acknowledgement, I thank the clinicians who have a big support in recruiting critical cases, finding cases which are worth doing whole genome sequencing. Dr. Akhilesh, Dr. Asmita from respiratory medicine, Dr. Praveena from pediatrics, Dr. Suhas from pediatric neurosurgery, and Dr. Lakshmi from MedGenome, and our team for allowing us to do these isolates whole genome sequencing. Thank you.